Welcome back to the deep dive. So today we are tackling a really fascinating question from you, the listener. It's a highly practical one, but biologically it gets pretty complex.
Yeah, it really does.
You wanted to know, can you start taking hormone replacement therapy, or HRT, while actively using the progestogen-only pill, the mini-pill, or do you have to stop that contraception first?
I mean, it is the perfect question. It really forces us to look at this incredible blind spot in modern medicine.
Right.
Because today we're drawing from a huge stack of clinical pathways. We've got documents from the Faculty of Sexual and Reproductive Health Care, the British Menopause Society, primary care prescribing guidance, and what's immediately obvious is just how poorly equipped the system is to handle this overlap.
The overlap between fertility and menopause, you mean?
Exactly. We treat them as two entirely separate biological events. But for a woman in her late 40s or early 50s, her body is actively doing both at the exact same time.
It's all one system. So let's just give her the short answer right up front. Yes, you can absolutely start HRT without stopping your mini-pill.
Yes, absolutely. All progestogen-only methods, so the mini-pill, the implant, the injection, they are completely safe to use alongside HRT.
They are. But, and this is a big but, the physical reality of how these two distinct treatments interact inside your body requires a delicate balancing act.
Because if you don't understand the mechanisms at play, you could easily leave yourself exposed to some severe, unintended health risks.
Right. To understand how to combine them safely, we first have to look at why the combined oral contraceptive pill is completely barred from this combination.
Yeah, that's a really important distinction.
The combined pill contains both synthetic estrogen and progestogen. And HRT, which is designed to relieve those menopausal symptoms, well, it also relies on estrogen.
Right, because when you double up on oral estrogens, the clinical data gets scary fast.
It really does.
The liver has to process all of that synthetic hormone, and that first-pass metabolism heavily stimulates the production of clotting factors.
Yeah, and that liver processing is where the danger lies. You are basically spiking your risk for venous thromboembolism, strokes, and potentially even increasing breast cancer risks. The body just isn't designed to process that high a volume of synthetic oral estrogen all at once.
Exactly. And that is why the progestogen-only pill gets the green light. By stripping out the estrogen entirely, the mini-pill acts as a highly focused, localized security system.
A security system.
Yeah, it thickens the cervical mucus to create this impenetrable physical barrier to sperm. And depending on the specific type of mini-pill, it alters the hormonal feedback loop to suppress ovulation.
All without adding to your systemic estrogen load.
Precisely.
You know, I like to look at this through a purely mechanical lens. Like, think of your reproductive system as a building.
Okay, I like this.
The mini-pill is the security guard stationed strictly at the front door. Its only job is keeping sperm out.
All right.
Meanwhile, HRT is the building's thermostat. As you enter perimenopause, your natural estrogen levels are just fluctuating and dropping.
Triggering all those vasomotor symptoms,
Yeah.
the hot flushes, the night sweats, the brain fog.
Exactly. The HRT is just topping up the estrogen to get the temperature back to a stable baseline. So the security guard and the thermostat are running on two totally separate, non-interfering circuits.
They don't interfere, which gives you the green light to use them concurrently. But, and this is crucial, this separation of duties creates a massive, potentially dangerous misconception.
Okay, what's the misconception?
Just because you are taking a progestogen for your contraception, it does not mean your HRT needs are fully covered.
Wait, hold on. This is where the clinical logic seems to, I don't know, fall apart a bit for me.
How so?
Well, the FSRH guidelines explicitly state that if you have a uterus, your HRT regimen must include progestogen to protect the womb.
Right.
But the mini-pill is a progestogen. That sounds like a perfect two-for-one deal. Why are the medical pathways demanding a second progestogen in the HRT regimen if you're already taking the mini-pill?
It is honestly the most frequent point of confusion for both patients and clinicians. The answer lies in the cellular mechanics of endometrial protection.
Okay, break that down for us.
So when you take estrogen via HRT to fix the hot flushes, that estrogen enters the bloodstream and inevitably reaches the uterus. Estrogen's biological imperative is proliferation.
Meaning it causes growth.
Right. It commands the cells of the uterine lining, the endometrium, to multiply and thicken.
So to visualize that proliferation, think of your uterine lining as a garden. Estrogen is this incredibly aggressive fertilizer.
That's a great way to picture it.
If you just pour fertilizer on the soil day after day, what clinicians call unopposed estrogen, the plants just grow wildly out of control.
Yes, and in the uterus, that unchecked cellular replication leads to a condition called endometrial hyperplasia. The cells become atypical, the lining becomes unstable, and that is a direct pathway to endometrial cancer.
Which is terrifying.
It is. So progestogen is the necessary countermeasure. To use your analogy, progestogen is the lawnmower.
Oh, I see.
It stops the estrogen-driven proliferation, keeping the endometrial lining thin, stable, and healthy. The problem with relying on your mini-pill to do this job comes down to pure pharmacological math.
The dosage just isn't high enough.
Exactly. The standard dose in a progestogen-only pill-take desogestrel, for instance, which is typically prescribed at 75 micrograms, it's engineered solely to alter cervical mucus and suppress ovulation.
Right, it's a very targeted, low-dose intervention.
Yeah. It is far too weak to effectively suppress the powerful proliferative effects of the daily estrogen you're absorbing from an HRT patch or gel.
So the lawnmower's motor is basically too small for the amount of fertilizer being used.
Exactly.
The security guard at the door might be great at checking IDs, but he doesn't have the equipment to put out a fire inside the building.
That is a perfect way to summarize it. And that fundamental weakness in the contraceptive dose is why you cannot just slap on an estrogen-only HRT patch while taking the mini-pill.
So the guidelines are rigid here.
Very rigid. If you keep the mini-pill for contraception, your HRT must be a combined regimen. Your HRT has to deliver the estrogen to fix your symptoms, plus its own heavy-duty dose of progestogen specifically calibrated to protect your womb.
Which means taking 2 different progestogens every single day. One for the door, one for the womb.
Yeah.
Though, the clinical data does highlight a fascinating, albeit off-label, nuance here regarding desogestrel.
Oh, the double-dose study.
Yeah. While the standard 75 microgram pill fails the endometrial safety test, there are studies suggesting a double dose taking 150 micrograms of desogestrel daily actually achieves enough concentration to protect the womb alongside HRT.
It's true. Taking too many pills a day is biologically sound in theory, as it drives up the systemic levels of the progestogen. However, large-scale randomized controlled trials validating this specifically for endometrial protection are pretty lacking.
Right, so it's not standard practice.
No, the medical authorities treat it strictly as an off-label use. It requires specialized clinical supervision because, from a licensing standpoint, the standard protocol remains unchanged. You need the dedicated HRT progestogen.
So, assuming you follow the standard protocol, you are swallowing your mini pill to prevent pregnancy, and you're taking your combined HRT to manage your symptoms and protect your womb, you are medically safe.
You are.
But the sources reveal this psychological and practical side effect of this combination. By taking these 2 treatments together, you are essentially throwing a heavy cloak over your body's natural warning signs.
Yeah, that's the bleeding mask.
You lose the primary metric for knowing where you are in the menopausal transition.
You really do. You are systematically masking the biological markers. The mini-pill, particularly desogestrel, frequently induces amenorrhea.
Which means it completely stops your periods.
Exactly. Or, alternatively, it causes random, unpredictable spotting. So if your periods have been artificially erased by the contraceptive, and your vasomotor symptoms like hot flushes are being artificially suppressed by the HRT,
You lose all your visual and physical cues.
you're flying blind.
And since the HRT doses are far too low to act as contraception, you're in this really strange limbo where you could technically still get pregnant while simultaneously treating the symptoms of ovarian failure.
It's a very confusing time for a lot of patients.
Which begs the question, how do you actually know when to stop taking the mini pill?
Well, the guidelines give us 2 specific, data-driven exit strategies. The first is the most straightforward, and it's based entirely on population statistics. It's the age 55 rule.
Okay, the age 55 rule.
Yeah. The medical consensus states that you can safely cease all forms of contraception on your 55th birthday, regardless of your bleeding patterns.
Because the data shows natural, spontaneous conception after 55 is, what, a statistical anomaly?
Basically, yes. The ovaries have effectively retired.
But many women don't want to wait until 55, especially if they are 51 or 52 and managing multiple daily medications.
And that brings us to the second exit strategy, which is the biochemical route. If you are over 50 and your periods are masked by the mini pill, a clinician can test your follicle-stimulating hormone levels, or FSH.
And since we know FSH is the hormone the pituitary gland uses to stimulate the ovaries, we're basically looking for the feedback loop to break.
Precisely.
As the ovaries fail and stop producing estrogen naturally, the brain tries to compensate by pumping out massive amounts of FSH. It's like it's shouting at an empty room.
That's exactly what's happening. So if that blood test returns an FSH level above 30 IUL, it confirms you have crossed the threshold into the menopausal range.
Wow, okay.
But, and this is a big but, the clinical pathways build in a mandatory buffer. You cannot stop the mini-pill the day you get those results.
Oh, really?
No, you are required to continue the contraception for 1 full year from the date of that specific blood test.
A 1-year waiting period, even with biochemical proof of ovarian failure, that really highlights just how cautious the guidelines are about perimenopausal pregnancy.
They are incredibly cautious.
Yeah.
The risks associated with unintended pregnancy in your early 50s, both maternal and fetal risks, are significant enough that the medical establishment demands an absolute ironclad guarantee that ovulation is permanently ceased.
That caution is justified, of course, but it leaves the patient managing an incredibly heavy administrative burden.
Oh, it's exhausting.
You're asking a woman to juggle a daily contraceptive pill, a daily HRT estrogen dose, and a daily HRT progestogen dose, all while navigating a multi-year waiting game. Any system with that many moving parts is highly susceptible to user error.
Absolutely. Missing a single pill or forgetting a patch introduces immediate risk.
You are basically hiring 2 completely different contractors to work on the exact same house. One contractor is running the security system, the other is managing the climate control.
Yeah.
They operate on different schedules, they require different maintenance, and you are the one forced to coordinate them. The obvious question is, why not just hire a master contractor who does both?
And luckily, the guidelines do present a master contractor. It is the single most efficient alternative for managing this physiological overlap.
Okay, let's hear it.
We were talking about the 52 milligram levonorgestrel intrauterine system.
The hormonal coil. Brands like Mirena, Levocert, or Benalexa.
Exactly. This specific device is a structural game changer because of its pharmacokinetics. It is the only contraceptive method officially licensed to pull double duty.
Oh, really?
Yeah. Instead of taking hormones orally and waiting for them to metabolize through the liver and systemic circulation, the IUS is placed directly inside the uterine cavity.
So it changes the entire delivery mechanism.
It does. It releases a steady, continuous dose of levonorgestrel directly into the localized environment. For the contraceptive side, this localized hormone instantly thickens the cervical mucus, blocking sperm with an efficacy rate over 99%.
So the security guard is permanently stationed at the door, 247, with no daily pills to remember.
Exactly. But the true value for the HRT patient is what that localized delivery does to the endometrium.
The lawnmower effect.
Yes. Because the levonorgestrel is being released directly into the tissue of the womb, it provides profound endometrial suppression. The concentration of the progestogen in the uterine lining is exponentially higher than what you could achieve with an oral pill. And yet, the concentration in your systemic bloodstream remains remarkably low.
Which means it is highly effective at acting like that lawnmower, constantly trimming the lining and preventing the HRT estrogen from causing atypical cell growth.
Right.
And because so little of the progestogen enters the bloodstream, you bypass a lot of the systemic side effects women hate about oral progestogens. You know, the mood swings, the bloating, the breast tenderness.
It's a huge relief for many women. The Faculty of Sexual and Reproductive Health Care explicitly recognizes the 52 milligram IUS as providing sufficient endometrial protection for up to 5 years of HRT use.
So the administrative burden vanishes.
Completely.
You drop the daily mini pill, you drop the daily oral HRT progestogen. The IUS handles both the contraception and the womb protection simultaneously.
Yep.
Then your only daily task is managing your estrogen levels through a patch, gel, or spray to dial in your symptom relief. It transforms a chaotic 3-part system into a simple, elegant mechanism.
It does. But we really must highlight a critical warning found deeply embedded in the prescribing guidance.
Okay, what's the catch?
The medical market is flooded with various hormonal coils, and they are not interchangeable. You have to ensure you are receiving the 52 milligram dose.
Because the lower dose coils fail the endometrial test.
Exactly. Devices like Kylena, which carries 19.5 milligrams, or Jades at 13.5 milligrams, they were developed to provide contraception for younger women with smaller uterine cavities.
And they work well for that.
They are highly effective at preventing pregnancy. But they do not release enough levonorgestrel to counteract the proliferative effects of HRT estrogen.
So if you are relying on a Kyleena coil while taking HRT estrogen, your womb is completely unprotected.
Completely.
You are essentially pouring fertilizer on the garden and hoping a pair of handheld scissors can do the job of a lawnmower.
That's exactly what it is. The guidelines are absolute on this. Only the 52 milligram coils are licensed for this dual purpose. Anything less, and you are back to requiring a supplementary HRT progestogen.
The 52 milligram IUS really represents the gold standard for perimenopausal care, precisely because it acknowledges the biological reality of this transitional phase. It treats the uterus as a single, unified environment rather than a collection of separate medical problems.
It does. It really does.
Which brings us full circle to the mission of this deep dive. You asked if you have to stop the mini pill to start HRT, and the medical consensus gives you a clear path forward. No, you don't have to stop.
No, the mini pill will keep you safe from unintended pregnancy without compounding your systemic estrogen risk.
But you must recognize the limits of that single intervention. The mini pill protects the door, not the room. It cannot guard your uterine lining against the aggressive cellular growth triggered by HRT estrogen.
Right, you cannot mix and match these hormones casually. If you choose to maintain the mini pill, you are committing to a fully combined HRT regimen to ensure that endometrial protection is in place.
You are committing to navigating the masked symptoms and relying on the age 55 rule or FSH blood tests to eventually safely discontinue the contraception.
Or, alternatively, you can bypass the daily administrative chaos entirely by transitioning to a 52 milligram hormonal coil, condensing both jobs into a single localized device.
It's all about making an informed choice. But, looking at these clinical pathways side by side reveals a broader structural issue in how we approach women's health.
It really does. For the last half-century, modern medicine has aggressively siloed the female reproductive lifespan. Family planning clinics handle the fertility control years. Then, decades later, menopause specialists step in to handle the symptom management years.
Like they're totally unrelated.
Yeah, the medical infrastructure is built on the assumption that these are isolated chapters in a textbook.
But the biology doesn't respect those clinical boundaries. A woman in her late 40s is living in both chapters simultaneously. Her body is winding down its ovarian reserve, which necessitates symptom relief, while still retaining enough unpredictable function to require rigorous fertility control.
Right. And we are forcing patients to act as the liaison between two entirely different medical disciplines that rarely communicate with each other.
It's incredibly frustrating.
The complexity of combining the mini pill with HRT is a direct symptom of that siloing. The friction isn't biological, it is administrative.
Wow.
It really makes you wonder how much safer and simpler perimenopausal care would be if we stopped viewing contraception and hormone replacement as distinct specialties. If the medical system fully embraced holistic hormone management, treating the female body as one continuous, evolving system, women wouldn't have to decipher these convoluted pharmacological puzzles just to feel normal and stay safe.
It is a profound shift in perspective. We don't have to accept a medical framework that treats the body like a series of disconnected mechanical failures. We can manage the entire interconnected system. So keep questioning the guidelines, keep asking for clarity on the mechanisms, and we will keep breaking down the research for you. Thanks for joining us on this deep dive.